Welcome, and thank you for coming to the webinar series from the Eye and Ear Foundation called Sight and Sound Bites. This bi-weekly webinar series, we started in April of 2020, and it's hard to believe it's gone almost a year already. We're going to highlight the research at the University of Pittsburgh Medicine. Today's topic is tackling the eye disease and pain of shingles. Obviously, I know a very popular topic that unfortunately people experience. So I'm Lawton Snyder, CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support. So thank you all who have supported our research efforts, and certainly we welcome any of those who'd like to learn more about how they can help support some of the research you may hear about today. During the program, this is Zoom, so you probably recognize Zoom now. I think most people had a chance to be on Zoom, but the chat feature is disabled. We'll ask you to use the question and answer function, which is the bubble at the bottom of your screen that says Q&A. You can use that to type in any question that you have about the program at any time. I'll read the questions at the end of the program, and the panel will answer and discuss those. We'll ask you to refrain from asking personal health questions. We'll probably pass over any of those and maybe get to you later, but and you can always ask through Craig Smith and your email if you have any specific questions for the clinical or research team. You'll receive surveys tomorrow, and that we'll appreciate you filling out the surveys. It's helped us a lot in deciding how we're going to present programs in the future. You'll also be added to our mailing list for future webinars. Today's program, as I mentioned, tackling the eye disease and pain of shingles, is going to be presented by two of our esteemed faculty, Dr. Paul Kipp, as we call him, Kinchington, who is the Joseph F. Novak, MD, Chair in Ophthalmology Research and Professor of Ophthalmology and Molecular Genetics and Biochemistry. He's at the Campbell Laboratory for Infectious Eye Disease at the University of Pittsburgh School of Medicine. And also joining him on the clinical side is Dr. Gaurav Prakash. Dr. Prakash is Assistant Professor of Ophthalmology and cornea, cataract, and external disease services at the University of Pittsburgh School of Medicine. So welcome, both of you. And I believe, Dr. Prakash, that you're going to get things started. So welcome, and I'll be back and join you later.
Thank you, Lonnie.
Thank you. Thanks a lot. Welcome, everyone. Let's get started. So we're talking about shingles today. We're talking about the problems it causes to the eye. And then once I'm done with the clinical aspects, Paul will start and we'll discuss about the research we are doing at University of Pittsburgh regarding this. So let's talk about what shingles is. Shingles is basically a painful rash which is caused by reactivation of the varicella zoster virus. Now, this is the same virus which causes chickenpox. So we all know chickenpox, we know shingles, they're basically caused by the same virus. Now, this can be potentially blinding. It can make the patient lose their vision forever. And even if you recover fully, it can have long-term neurological and healing problems. And that's why it becomes a public health crisis. 1 of 3 people will develop shingles. So if you have 3 friends, look at the pictures in your mind, most probably one of them in their lifetime is going to develop shingles. It's that common. The risk increases in senior years, and the CDC has recently noted that the risk increase is actually exponential. That means as you grow older, it does not grow, the risk does not grow straightforward. You are at a higher risk when you're more than 50 years of age. And this has been the traditional teaching that if you are older than 50, you have higher chances of shingles. Unfortunately, now this scenario is changing. You have got younger population in clinics who are coming in with shingles, people in their 30s, 35s, even sometimes younger people have shingles. And this is a worrisome trend. Shingles does not differentiate. It hits all demographic subgroups. And the risk increases with conditions which can cause your immunity to go down. It could be stress, but mostly immunosuppression is caused by conditions such as HIV, cancer, diabetes, or when you're undergoing chemotherapy. However, as I talked about, younger people in shingles, similarly, people with normal immune system can also get shingles. So it is a problem. So now let's look at this, the development of shingles. When do you develop shingles and what happens? So chickenpox is the first part of this disease spectrum. When you're younger, in your earlier life, or sometimes rarely when you are even old and you never had chickenpox before, you develop the classical chickenpox. It heals, but the virus never goes away. So think of this as a cross-section of your skin. The virus goes down inside the nerves over here, somewhere over here, and tends to hide inside the nerves. Virus keeps on staying in those nerves. And whenever you have a situation when you have reduced immunity, the virus tends to reactivate. So look at this as the nerve endings. The virus is staying over there dormant nicely. You have even forgot that you have had chickenpox before. And reduced immunity makes the virus come up to the surface and reactivate, which presents as shingles. So the cycle is like this. You pick up chickenpox first, the surface heals, but the virus stays inside your body, inside the nerves. Under episodes of reduced immunity, diabetes, stress, HIV, immunosuppression with chemotherapy, the virus reactivates and causes shingles. When you have shingles, there are certain stages through which the body undergoes. The first phase or the early phase is when you have no rash, but just have the clinical features of malaise, fatigue, fever, and you have got itching and burning on one side of the face or the body or the trunk, depending on what type of shingles involvement you're having. This develops into the next stage in which you develop the classical rash, which is typically 24 to 48 hours after developing shingles. This rash is typically one-sided. Shingles does not involve bilaterally until very, very rare. It is involving only one side of the body. And this is the time when you develop the pain and the complications. Now, the reason why this is important is many a times patients who have mild malaise or fever or fatigue who are in the early phase will actually be missed. That means we'll not come to know that they have shingles till they develop the rash. You might come to the ER or go to your PCP and we might just think that you have early viral prodromes and you might have to go back home. This is a very common situation. The next step is the ulceration phase. The ulceration phase happens around 3 to 4 days from the zero phase, in which these blisters, they open up and start ulcerating, and the pain and the complications continue at this point of time. This is a really painful period for the patient. By the 7th to 10th day, depending on your immune system, if it's healthy or not, the ulcers heal by scarring. And by this time, most patients are non-infectious. So you can go back to work at this time. You don't pass on the risk of passing the virus to anybody else by the time you develop scarring. The long-term sequelae persist, but around 30 days is when your rash starts to disappear. And sometimes you can have the rash sticking around for a very long period of time, the discoloration of the rash, I'm sorry, not the rash. It's also okay to vaccinate somebody 30 days or longer. It's debatable, and Kip will talk more about the immunity after the first episode. But many a times it has been asked that when is okay to vaccinate. So beyond 30 days, when you don't have the classical infection, you are okay to vaccinate back again for shingles if needed. Let's talk about the eye complications. The eye complications have a blanket term called as herpes zoster ophthalmicus. Fortunately, the eye is spared in around 98% cases of shingles. That means the area which involves the eye, nerves which involve the eye, are not affected. Only 2% cases develop that. But there's more to this problem. Of these 2% cases, whoever gets shingles, most of them who get the ophthalmic symptoms are actually at a risk of losing their sight. So these are potentially sight threatening. There are a lot of complications which can happen, and we'll cover them slightly over here to get an idea in the next slides. But shingles can actually involve, or rather herpes zoster ophthalmicus can actually involve any part of the eye. The most common involvement is an infection of the cornea, which is painful. You have difficulty in blinking, you have foreign body sensation, and that's the initial presentation mostly. This can lead to something called as corneal scarring. Now, your cornea is the front part of the eye. It should be absolutely clear for light to travel inside the eye and for you to see well. But if you develop a scar in front of your cornea, light cannot pass in the eye that's the way it's supposed to go. And then you get halos and glare, and sometimes even loss of vision because of this. Now, in a normal corneal scar, we try to do lasers or we try to do corneal transplants to make them feel better. The problem with shingles is, as we talked about, that the virus never goes back again. And the virus actually takes away the healing potential of the eye. So even if you do a corneal transplant, there's a very high rate of corneal transplant failure in patients who had unfortunately had shingles. So we are looking at a double whammy over here. First, the virus causes problems and scars. And then second, when you do an intervention, the healing is very, very poor because of the damage to the nerves. You develop something which is called as a neurotrophic cornea. That means the cornea does not have any nerve endings which are active, and it takes away the incentive to heal. It can also cause inflammation in the middle part of the eye called as the uvea, or the back of the eye, which is called as retina. And again, these are sight-threatening complications. So all in all, herpes zoster ophthalmicus, or the eye involvement in zoster or shingles, even though it's seen in maybe 2% patients who develop zoster, 100% of these patients are at risk of sight loss, and therefore it becomes an ocular urgent situation. It needs to be tackled immediately. Now, before we go to treatment, I want to answer one question which has been asked many times in the clinic settings for us. Is shingles contagious? So the simple answer is that shingles is basically a reactivation of the virus which you already host from before. You had chickenpox and then you're having shingles. So technically, shingles is not contagious, but you can get chickenpox from somebody who had been infected from shingles. Let me explain this once more. Let's say somebody was never vaccinated and they never had chickenpox. And now you come in contact with somebody who is having early shingles and they have ulcers which are infected, right? In that situation, if you get the virus from them through a direct contact to the skin of a shingles blister, or rarely, and that's rare, don't get scared about that, it's rare, by breathing the zoster virus through the air, you can actually pick up chickenpox from these people. So if you never had chickenpox in your life, or you were not vaccinated, you are at risk of catching the virus, which can manifest as chickenpox in that first episode. Unfortunately, not shingles. Treatment. So the silver lining in the story is that we have a straightforward and fairly effective treatment for shingles. We need to start a full dose of oral antivirals as soon as the diagnosis is made. The treatment of choice is a medicine by the name of valacyclovir, which is known by the brand name Valtrex. It specifically acts on cells which have been infected with the virus, and therefore it does not cause damage to the normal human tissue, which is a great fact because it can be given to a lot of patients on a very long period of time. In fact, patients who undergo ocular surgery after shingles, probably a cataract surgery, sometimes even a transplant, we have to give them even lifelong support with Valtrex in some cases. Other supportive treatment includes steroids, lubricants, and antiviral ointments based on the clinical features. But as a patient or as somebody who's going to take care of somebody who will have shingles in future, as a care provider, you should know that antiviral pills are safe. They can be given in the long term, and they are the treatment of choice in patients who develop shingles. Let's talk about the role of vaccines. I will cover this briefly because Kip is going to cover in much more detail regarding this. Shingrix is the recombinant zoster vaccine we give as a vaccine of choice in the United States right now. 2 doses, 2 to 6 months apart. And it's typically for immunocompetent patients who are more than 50 years of age as of now. You should take it even if you had a prior episode of zoster, as he talked about in the slide some time back. But you should wait for the current episode to resolve. You should not take it on day 7 or day 10, probably take it after a month. If you had a prior dose of the previous vaccine, Zostavax, which is not available in the US anymore, you should again take Shingrix. It's more effective compared to the previous vaccine. You can take it when you have chronic medical conditions, unless there is a specific contraindication or precaution needs to be there. In case, if you have immunocompromised, does it rule out the Shingrix vaccine totally? No. There are certain situations in which you can give it in immunocompromised adults also. One of them is if you're taking a low-dose immunosuppressive therapy like mild steroids. If you're anticipating immunosuppression, that means you're going to be started on medications which can reduce the immunity. You can take Shingrix vaccine, that's absolutely fine. Or if you have recovered from an immunocompromising illness and you don't have immunocompromise, you are fit to take the Shingrix vaccine again. At this point, I'd like to stop my presentation. I'd like to thank my clinical team at the Coronary Refractive and External Disease Services. And I'll pass it over to Kip to continue with the rest of the presentation.
Thank you, Dr. Prakash. Okay, I'm going to take over and tell you a little bit about some of the research we're doing. And I'm also going to just reiterate a couple of points that Dr. Prakash brought up so that it's you have a good memory of this. So just as a disclosure, I am a paid consultant for Merck & Co. So as Dr. Prakash pointed out, shingles is a disease that happens as we age or we get sick from elderly diseases, and it rises rapidly after 50 or 60 years old. And about half of people get it by the time they're 80. So it really rises quickly. And it's estimated that about 10% of 80-year-olds have had it twice. So, as we pointed out, this is because your immunity declines naturally with age, or it drops with diseases such as cancer, transplants, particularly bone marrow transplants, or if you're infected with HIV and AIDS. So while we know this is an elderly disease, this is a graph that shows you the rates of shingles that is happening. While in 70-year-olds and 60 to 70-year-olds, it's flattened out over the years. Notice there's an increase in 50 to 60-year-olds and 40 to 50-year-olds. It is rising, and one of the things we're trying to do is to understand what might be the predisposing factor for this age increase. So it does affect people we know. Tony La Russa, the manager of the St. Louis Cardinals, had it at the age of 66. It stopped his games for many weeks. He had facial pain, light sensitivity, and was in bad shape and temporary loss of vision. And it's not just the older folks. Lin-Manuel Miranda, who wrote Hamilton, got facial shingles recently, just last year. He tweeted he wanted a lefty phantom mask, which didn't quite fit. But it points out that shingles can affect you at young ages as well. And the one that I know well is David Letterman, who had facial shingles in 2003. He was only 55. He had vision problems, and he did get a pretty bad eye infection. He got pain, long-lasting itch, and it was only this and his heart bypass were the only things that stopped his appearance on the Late Show. And he did a top 10 good things about having shingles, which involved many swear words, and also top things to stop you from scratching. So, you know, it's not such a funny thing anymore. And I just want to bring this up. So chickenpox is a skin disease, but it eventually has to travel down these nerves, your sensory nerves, and it hides in the dorsal root ganglia. And in the case of the eye, this is the trigeminal ganglia, which is near the brain. And that is where the virus resides for decades. And then something triggers it, and it has to come back down these nerves and then appear at the skin. Now, because the nerves are involved, it very often damages the nerves. And so that's one of the big problems with shingles is the nerve damage. So you end up with a nerve. It could either leave it normal, or it does two things. One of them is it makes it what is known as neurotrophic, where you lose sensation. There is no sensation at all. And this happens in the cornea, as I'll mention next to. The other one is neuropathic, and this leads to pain. And what we're trying to understand is what defines whether the virus is going to do a neuropathic pain or a neurotrophic lack of sensation. So here's a case of neurotrophic, where it stops nerves from functioning, which is shingles-induced anesthesia of the cornea. Dr. Prakash mentioned this. So your cornea has lots of nerves in it. When shingles affects your eye, all these nerves retract or they become non-functional so that you actually lose sensation in your eye. The effect is it makes your cornea go numb and you don't know when you've damaged it, such as putting eye drops in, which we all do when we're a little older. And then you can scratch it and get a bacterial infection. At the other end of the spectrum is pain. 90% of shingles people want some kind of pain relief. And about a third of patients develop this chronic, long-lasting pain, which can last for years. And for reasons unknown, that in the face and the ocular region is often more severe. And it's difficult to treat. Many patients get no benefits from any kind of treatment. You know, as I said, you hate your life. And we're trying to understand why acute pain becomes chronic pain. So, and I'm just going to reiterate this. So one of the worst types of shingles pain is known as allodynia. And this is where something like a feather or hair or clothing or a wind gust even makes it really, really painful. And then if you take this away, it still echoes on pain. So allodynia makes life very difficult because you can't wear clothes. You can't deal with, you don't want your hair in your face because it drives you such pain. This could be really difficult to treat. It can last for years. So just two people that have had shingles, bad shingles pain is Roseanne Barr, who said it was the worst pain that she'd ever had. And Richard Nixon, who was really badly capacitated by the long-term effects of having shingles. So what could be done about shingles? As Dr. Prakash mentioned, get vaccinated. The vaccines do work for most people. So this shows you the kind of vaccines there are. So for chickenpox, we've had a vaccine since 1996. This is a live attenuated virus, which means it's a weakened form of the virus that normally causes chickenpox, and it's given to young children. It works really well, and still most children in the US are getting this vaccine. It has very rare side effects, but for the most part, this is a vaccine that almost everyone gets. And the age is about 30 of people that have this. Most people under the age of 30 have been vaccinated. The shingles vaccine was very similar to Varivax. It's based on the same virus, but it's 10, 12 times more powerful. And it was given for 10 years or more to adults over the age of 50. And it cut down shingles by about half, and it reduced the pain or the burden of disease by about 2/3. This was a pretty good vaccine for 10 years, although the immunity did not last a long time. And it was recognized that it's not a good vaccine for the immunocompromised because it is a weakened live virus. And it didn't work so well at higher ages, but it was the best thing that we had. The new vaccine, which just came out a few years ago, is Shingrix. It's a subunit vaccine. There is no live virus. It's just one of the proteins that the virus makes. It's given to adults, and it's given as 2 injections 2 months apart. It can have some painful side effects, and this we have to be careful of because people don't get their second dose. But the protection seems to be longer lasting, and it can be given if you've had the Zostavax already. But there is a little bit of a problem, is that most shingles patients are elderly, and they're not keen on generally getting a new optional vaccine. And many people don't know how bad shingles and the pain can get. So I'm going to bring up our research then, use that as a transition to research. So we have this journey that goes down nerves and it hides here, and then it transports back. My lab and group study how the virus resides in this ganglion and how it goes up and down these human neurons. Now, half the problem that we've had is that we've had to work with human neurons. You can't use animal models to study some of these latency and reactivation mechanisms. So to do that, we make human neurons from human stem cells. This is a picture of a human stem cell, ball of human stem cells growing, and we can direct that down a pathway so that it forms these axon projections that are coming out. And then we eventually end up with these balls of neurons, of which many of them are sensory, and they project all these axons out. This allows us to, in a dish, to be able to study vis-a-vis latency and ask the question what the virus makes in neurons. What are the triggers that cause the virus to reactivate from its latent state or quiet state? And how it moves along these tracks to get from the nerve cell body to the skin, the periphery. This is a particularly interesting area. We're starting to actually come up with a shingles in a dish, if you were. So we have these little chambers, which I'm showing here. They're about 1 centimeter across. And in this region right here, we have little channels. And this is an enlargement of those channels. So what we can do is we can seed those precursor neurons on one side, get them to grow their axons through the channels, and then we can say this is like the periphery, the skin, and we can infect the virus, watch the virus go up to the neuron body and go latent. And then we can also watch it come back down and infect the skin, or as we've been using, corneal cells, which represent the eye surface. So this is a picture, for example, of looking at one of these channels right here. And this is the channel. You can see these axons. And these little green dots are viruses that we can label so that they're green. And this picture here shows a picture of one of those viruses actually moving in an axon towards the neurons in the ganglia, or the model of the ganglia. And we can actually get pictures and films of the virus coming back down as well. So we're using this cultured neurons, and we're asking these questions. How does the virus travel? It's got to go in 2 different directions, because when it sets up latency from chickenpox, it has to get to the ganglia. And yet to cause shingles, it has to go from the ganglia back to the skin or the eye. So we're looking at how the virus does this and what proteins are involved, and can these be targeted? The second question is what does the virus do in nerves during that long latent state that lasts for decades? And what do they do? I mean, can we stop them from allowing the reactivation and shingles to develop? And then what are the triggers of VZV to renew its growth and cause shingles? Can we prevent those? Finally, we're trying to remove the latent virus from the ganglia using new methods. Some of you may have heard of the CRISPR methods that are used for gene altering. We're trying to apply CRISPR to be able to remove the latent virus from neurons using this culture system. So the second part of our research was pain. How does VZV cause chronic pain and this long-term pain of post-herpetic neuralgia? So we have a new animal model of shingles, face, skin, and eye pain, which uses rats. And what we can do is we can put virus into the regions around the eye, and it goes to the trigeminal ganglion, and it signals pain to the brain. So VZV is put at a rat whisker pad, and the virus gets to the trigeminal ganglia. Humans have the most virus in their trigeminal ganglia. So how do you get a rat to tell you it's pain? Well, this is how we do it. So we put the rats in an enclosure like this, and half of it is dark and half of it is clear. And what we do is we put virus on one side of the face, and they're not, because rats are nocturnal, they will like to stay in the dark side. They hang around here. But what we do is we give them a stimulus, and we touch the side with the virus in them if their head is in this side, and we touch the other side as the control if their head is in this clear side. And I'll show you one little bit of data. These are the controls. And you see that over time, the animals stay in the dark side. This is the time spent in the dark side. They stay there. They don't move out from the dark side. Whereas if they've got virus and we're touching them on the side with the virus, they move to here because they want to avoid being touched. And so the animals are feeling hypersensitivity. So basically rats with pain, they move to the clear side to avoid touch. And this is against their natural behaviors. And the lab has a little joke that these are what we call Star Wars rats because they avoid the dark side. So we're using this model to understand how VZV alters the nerves to signal pain, and then also block nerve sensation in the cornea. We're looking to see if these pathways could be targeted to prevent pain from developing. And we're using the model to test new treatments that might more effectively block shingles chronic pain. And one of these approaches is to actually test gene therapy systems to block the pain, which we think have the potential to be used in humans. So I'll finish up there. This is the lab. This is my group in the lab a year or two ago. We have current and former members. All this work was done in collaboration with Ron Goldstein at Bar-Ilan University, who is an expert on developing human neurons from stem cells. And the face model was developed with Phil Kramer and Bill Goins. And our support. I just want to mention our support was from the National Institutes of Health. We've also got research from Research to Prevent Blindness and the Virginia Kaufman Fund. But the Eye and Ear Foundation has been key to developing these kind of tools. So I'll end there. Thank you for listening. And if there's any questions, you have my information.
Thank you, Dr. Kinchington and Dr. Prakash. that's a fascinating presentation on many levels, and I already see that we're getting many questions. And as someone who's experienced shingles with family members, I know that this is something that obviously profoundly affects people's quality of life. So thank you for the work you're doing. Let me get to some of these questions here. For one question here relates to, and I think you did mention it, Kip, but what's the name of the old vaccine that's no longer effective? And
I'm sorry, Lonnie, I can't quite hear you. Your sound is a little burgled.
Okay. Is it better? No?
No, it's the same, Lonnie. Unfortunately, it's same here.
You know what? I ask Craig, can you jump in here? Sorry about that.
It's getting a little better.
Okay. Let's see here. Any better? I'm sorry.
Try and ask your question, and I'll see if I can answer it.
Lonnie, I can ask a question here. So the first question we have, Kip, it is what is the name of the old vaccine which is no longer effective, and when was the newer vaccine started to be used regularly? And then the second part of that is, are there plans to offer the vaccine to younger individuals?
So the older vaccine was known as Zostavax, and it was marketed by Merck. That was a live virus vaccine. That started in 2006, and there are places that still use that vaccine, although it's generally not as well used in the US. The new vaccine started in 2018, and that is called Shingrix. That is given as 2 doses, and it's not a live virus, an attenuated virus. It's a subunit with a new adjuvant. And it's now recommended that be given and used in the US.
So kind of a follow-up to that question is, can one get the Shingrix vaccination in conjunction with the COVID vaccine, or should they be spaced out?
They should be spaced out. The reason for that is usually the vaccinations are a little painful. Because they generate an inflammatory response at the site of injections, and it's better to get them separated at different times. I just wanted to answer the question that came up. You said, is there chances of getting a vaccine at younger ages? At the moment, it's probably, it may be being studied, but it's not recommended for people under the age of 50 because the shingles is a disease that still really, in the majority of the population, as you get older, it develops. Young people do not generally, although there's lots of exceptions, of course. But the number of people that get it at a young age is perhaps difficult to justify wide use of the Shingrix vaccine. But there may be trials that I'm not aware of that might be looking at that.
So the next question we have, I think this would be interesting to anybody who might have or has shingles already. If a person has had shingles previously, can they get it again?
Yes. There are so having shingles will boost your immune response. It'll charge your immune response, but your immune response still is declining as you age, and you may get immune suppression. By the time you're at 80, it's estimated that about 10% of people have had shingles twice. And there are some individuals that get many more episodes of shingles, and we do not know why those people get many bouts of shingles. It may be something to do with the genetics of their immunity, or they may become immunosuppressed because of treatments. But yes, you could get shingles twice, and the older you get, the more chance of having a second bout rises.
The next question is geared more towards the research side. Very nice talk. If you vaccinate the rats with Shingrix, will that lessen their pain after the VZV injection in nerves?
That's a really good suggestion, and we are looking into that. We're looking to see whether the immune system increases or decreases the pain. There's an option for both because a lot of pain is caused by inflammation. The reacting against the viruses is growing in the ganglia. So there's one option where it might cause more pain, but it may also prevent the virus from growing and stop the inflammation. So that question is something I don't know the answer to, but yes, we're really interested in if a vaccination could stop the pain. One thing I will mention is that both Zostavax and Shingrix greatly reduce the level of pain seen in humans. So if you get shingles, the consequences of it are much, much less painful.
That's good. That's good. So in current climate, of course, we're getting a lot of questions about COVID. The next question is, if the second COVID vaccine was given, how long should you wait to get the shingles vaccine?
Dr. Prakash, wouldn't you say it would be about 4 weeks at least?
Yeah, I think so. I think so. 4 weeks should be good enough time before we give two different vaccines because of the reasons Dr. Kinchington was telling. It's more like a comfort that you don't have two vaccinations close to each other, let the body mount an immune response. But yes, that ballpark is good enough. 4 weeks should work.
Okay. Similar question. So this person asked, I missed the second dose of Shingrix due to COVID. Can I get dose 2 at 8 months after the first dose?
Yes, you can get them. There's some studies that have looked at, spreading out the time, but it's very important to get that second dose because that second dose really charges up the immune response and the protective level that is given. So yes, the second dose is very important to get, even if it's a little delayed. It's very important to get the second dose of the Shingrix.
Okay. What is the current pain management for shingles, and is it effective?
So this is a tricky one. The pain management for shingles is quite varied. There are mild treatments, and there are very harsh treatments. There's a drug called gabapentin, which works very well for most people. There's some drugs called tricyclic antidepressants. They have also been used by many to suppress the pain of shingles. There's even opioid treatments, but they tend not to work for some people. There is a group of people so there's many treatments that the physician and neurologist will offer you, and he could try them and vary them. There are a small fraction of people, though, that don't get any effective treatment from any of the treatments. And that's because pain is a consequence of many different things. And it may be that sometimes the virus does something that just current treatments don't work. And so there's always new developments for pain management of postherpetic neuralgia that are being evaluated and developed and investigated.
Should a person get the vaccine if they had chickenpox as a child?
Yes.
Which vaccine?
I would believe they'd be talking about Shingrix.
So if you got chickenpox as a child, yes, because Shingrix is designed to block the reactivation of the virus that's already in you. Now, the physician will ask if you have had chickenpox before. And if you can't remember it, they might do a test. You should not get the live vaccine. The live vaccine if you've never, the live Zostavax, if you've never had chickenpox. So that's physician recommended, and they'll do that case by case. I will point out that it's very difficult in the US to go through life without having had chickenpox. This is a virus that infects the vast majority of people, particularly as childhood, any kind of group gatherings. And a lot of times chickenpox is almost subclinical in that it doesn't cause a lot of physical disease. It doesn't cause a huge amount of rash. So it's sometimes could be asymptomatic and you've got the virus and you don't know you've had it. There's a test that can be done, which just measures the antibody levels to the virus. And that's good to do, perhaps, because if you get chickenpox as an adult, it could be more dangerous. There are certain things that can arise as you get chickenpox as an adult. One of them is a pneumonia, which is more common in adults than it is in children. And that pneumonia can lead to hospitalizations. So
we'll kind of combine two of these questions here. If you received the shingles vaccine, the 2-dose shot, should you get it again in 5 to 10 years? You know, are there boosters or is it just a once and done vaccine? Dr. Prakash, maybe?
I mean, the effectiveness of the 2-dose combination is more than 90%. So as of now, CDC does not recommend a booster.
Great. Okay, next question is, I think you covered this very briefly, but what is the age recommendation to get the vaccine?
It should be 50 years or more. That's what we're looking at right now, because as Professor Kinchington was telling, the benefits of vaccinating people younger than that is much lesser.
Okay. And this is an interesting question here. Are there any foods that you should avoid or that you should eat that would help with the symptoms of having shingles?
Not that I am aware of. I do not know of any recommendations or guidance regarding eating with regards to shingles. I don't know of any.
Same here. I don't see any specific dietary patterns which can help.
Okay. So you had mentioned earlier for a question that you can have shingles again after you had it once. So this is kind of a more specified question. If you had serious chicken pox with an infection in your ears, your eyes, or your nose, are you more likely to get shingles in those specific areas later in life?
It's a luck issue. When you get chicken pox, the infection goes all over your body and it sets up latency all over your body. And the highest amount of virus is often in your trigeminal ganglia, which infiltrates your eye. But the most common place to get shingles is often on the body trunk, on one side of the torso. So it's a matter of luck or bad luck as to where the virus will reactivate, which ganglia, the specific places that the virus wakes up, with the torso being the most common. The face is less common, but is more risky to the eye.
Okay. And is it possible to have shingles in both eyes? One of the concerns with shingles is if it crosses over the body, either up to down or left to right.
That's a great question. Now, the risk of having, let's go back a bit and try to explain what's happening over here. There's something called as dermatomes, or these are the areas which specifically a nerve innervates in the body. So having two or more different dermatomes on the same side getting involved is a possibility in patients who have immunocompromise. And there's a term for that is called as herpes zoster duplex bilateralis. That means you have two areas supplied by two different nerves, which are not involved in different halves of the body. So that is a rare reporting. It's less than 0.1% of all zoster cases. There is an extremely rare variant also in which you have the same nerve on both the sides getting involved. So that's bilateral symmetrical involvement of zoster lesions. The name for that is herpes zoster duplex symmetricus, which is very, very rare. It is so rare that I think till the last year, there have been only 4 cases, and one of them was a pediatric case from Middle East. So 4 cases have been reported so far. So it's extremely rare to have shingles at the same time in both eyes. And as I said, I haven't heard of a clinical situation like that. It doesn't cross over to the other side, definitely.
There are cases, though, where the virus, you can get systemic infection.
Yes.
Once in a while, the virus doesn't just cause a rash on the dermatome, but it can infect the whole body. And it spreads throughout the circulatory system.
Could you give the statistics again on the percentage of people that contract shingles after the age of 70?
So the numbers that happen after 70, the incidence, can I refer to my slide? The incidence of shingles after the age of 70 is about 6 per 1,000, 6 to 8 per 1,000 persons. So it's as you age, the amount increases. As I say, there's a third of people are going to get it in their lifetime. That means 2/3 will not get it. So a lot of it is like, how important do you think you are? How lucky do you think you are that you might be in that 2/3 as opposed to that 1/3 that will get it? And as you age, it's more likely to develop.
Okay. Here's a really interesting research question. The rats exhibit neuropathic disease. Is that because their nerves don't retract upon infection?
So they actually, very interesting, good question. They actually do retract the nerves. And actually that's a neuropathic sign of nerve damage, is they pull their nerves away, but they become hyperexcited. In was one model we have from the skin, the nerves become hyperexcited and they, for some reason, become extremely sensitive to any kind of sensation. And we're looking at the mechanisms why that is. Even though they retract from the skin, they could still transmit to the nerves the sensation of touch, and they become hypersensitive and still undergo that hypersensitivity and transmission of pain. And the interesting thing is once the pain is there, it continues, even though we take away the stimulus.
What about L-lyseum, L-Y-S-E-U-M? Does that help at all?
I do not know. I'm going to be honest, I'm unfamiliar with that treatment approach.
Dr. Prakash, do you know at all?
So I think they misspelled it as L-lysine. So lysine is amino acid. I'm not sure whether there is a direct proven role of that in pain, if I'm reading the question correctly. Dr. Kinchington, do you have any idea on this, on the role of lysine?
No, I don't.
Okay. Next question is, does the vaccine prevent or decrease further episodes of reactivation of the virus?
Dr. Prakash?
I mean, I agree with you. You are the expert in the vaccine.
Yeah, sure. It looks like the vaccines are effective.
Exactly.
They clearly reduce the incidence of shingles from developing, and they block most of the reactivation. So, as I say, this is a recommendation from the CDC is to get your shingles vaccine and don't put it off if you're over the age of 50, because as I pointed out, a lot of people underappreciate how bad shingles can be. And there's a small group of people where it alters their life. That number is not huge, but there are people out there that their whole quality of life is just lost because they don't want to go out. They lose contact with other people. They lose vision. There are cases where it can really, just one episode of shingles can really damage the visual axis so that you cannot see. I don't think you want to risk that game.
Right.
And the vaccine is quite effective. The vaccines are good.
So I'll do a quick repeat here. Somebody missed the answer. They're asking how long after the Shingrix vaccine should you receive, or can you receive the COVID vaccine? I think you guys said about 4 weeks.
I think 4 weeks is good.
Okay.
I'm going to test my audio again. Did I come back again? Or
yeah, you sound good, Lonnie. I'll let you close us out.
All right. Well, I apologize to everybody for having that. That's why we have people on standing by in case there's some technical difficulties. So Craig, thank you. You did an excellent job. And thank you everybody for coming on. And I want to thank our panelists today. Again, a very interesting program. So, and obviously one that's very important. So thank you, but also thank everybody who joined us today for our Sight and Sound Bites and this obviously very important topic on shingles and how it affects our vision, how it affects our quality of life. So as I think we can all say from listening closely to today's program, the most important thing you got out of it, if you didn't get anything else, when you're old enough, get your vaccine. I mean, I'll share with you, I already have. So thank you all, and have a good rest of your day.
Thank you for your interest.
Thank you for your interest. Thank you. Have a good day.